This is the final discussion or recording related to blood gas interpretation. In this particular presentation, we're going to actually interpret some blood gases in a couple different ways, showing you some different things that might be helpful. Again, if you understand the process, this would be a good review for you too. Okay, we use arterial blood gas analysis as it is an essential part of diagnosing and managing oxygenation status and acid-base balance. Usefulness of this diagnostic tool is very dependent on being able to correctly interpret the results, and it doesn't say this here, but it's also very useful if you can do it fairly quickly and not take a lot of time. And so I've included in this presentation some steps to help you with that. First of all, remember from our previous two presentations, the pH basically is a measurement of the acidity or alkalinity of the blood. The pH level is inversely proportional to the hydrogen ions in the blood, meaning that if there's more hydrogen ion, there will be a lower pH, and if there is less hydrogen ions, there is a higher pH. We measure pH on the scale from 1, which is very, very acidic, to 14, which is very alkalotic. Liquid that has a pH of 7, like water, is considered neutral, although the normal blood pH range is a little bit on the basic side, 7.35 to 7.45. Start to memorize these numbers. If the body pH is below 7.35, the blood is considered acidic. Body does keep its fluids in a very narrow range from the 7.35 to 7.45 at all times. So when the pH is below 7.35 and the blood is acidic, the body will actually react very negatively to that acidic state. There might be a decrease in the force of cardiac contractions or in the vascular response to catecholamines such as epinephrine, norepinephrine, dopamine that help with blood pressure. So your stress or fight or flight response is impaired. And of course, this will also diminish the response to different medications. When the pH is above 7.45, blood is considered to be alkalotic. The alkalotic state interferes with tissue oxygenation and can interfere with neurological and muscular functioning. So pretty much the blood is kept, or the fluids in the bodies are kept at that 7.35 to 7.45 level. When it gets much above 7.8 or below 6.8, and if it is uncorrected, it will actually lead to death. Okay? Remember, we have the systems that the body uses to self-regulate acid-base balance. They're called the three systems here. There's a buffer mechanism with respiratory and renal buffer response. Remember, there are actually buffers in the system itself in the form of proteins or bicarb that can bind or release hydrogen ion pretty much like a sponge. Or there is the respiratory buffer response, where the lungs either increase or decrease the rate and depth of ventilation until that CO2 level is appropriate. Remembering, of course, that CO2 and hydrogen ion tend to move along the same pathways. When CO2 is up, hydrogen is up, and vice versa. So activation of the respiratory system or the lungs to compensate for any imbalances is pretty quick, within 1 to 3 minutes. And that's going to be my cuckoo clock again on the background. Wait till it's done cuckooing. Okay, and the renal buffer response is the kidney's response to changes in the acid-base balance, and that involves the excretion or retention of the bicarbonate ion, which will actually bind with the hydrogen ion and in that method, it will actually bring the pH level back to normal. However, the kidneys are not as quick of a response as the respiratory system or the lungs. Might take hours, a days, 2 days for the kidneys to correct any imbalances. So let's first talk, kind of review respiratory acidosis. Again, it's where the pH is less than 7.35 with an increased PCO2 greater than 45. Again, all of the conditions that are listed here as kind of a review for you will cause respiratory acidosis, and in general they are any condition that causes the person to breathe incorrectly or to hypoventilate. Okay, so anytime there's a depression to the nervous system or impaired respiratory muscle function, pulmonary disorders, hypoventilation due to injuries, all those kinds of things cause respiratory acidosis. Respiratory alkalosis, on the other hand, pH greater than 7.45, with the PCA2 now dropping less than 35, in general is any condition that causes hyperventilation or too rapid of breathing. So the carbon dioxide is actually breathed off, and that will cause the pH to rise, for everything to become more alkalotic. Anything that makes you hyperventilate, anxiety, fear, fever, sepsis, some medications will do it, and any lesion in the central nervous system, especially in the medulla oblongata, that might make respirations higher than normal. Metabolic acidosis is defined as bicarbonate levels of less than 22 milliequivalents per liter with a pH that is also low, 7.35 or less. It is caused by either a deficit of the base, not enough bicarb, or there's an excess of hydrogen ion of something other than carbon dioxide, in fact, something that would actually release hydrogen ions. Causes of losing your base, losing the bicarb, diarrhea or intestinal fistulas. Causes of increased acids include renal failure, diabetic ketoacidosis, anaerobic metabolism, anything that would cause increased production of acid in the system. Metabolic alkalosis, on the other hand now, the bicarb level is high, which makes the pH high, and that is usually either an excess of bicarb or a loss of that hydrogen ion. So when we have excess bicarb, usually it's because of over ingesting or eating of antacids, excessive use of bicarbonate, which is kind of like Alka-Seltzer or something, again, kind of an antacid, but with a little more kick to it. Use of lactate in dialysis, that can cause it. And then cause of losses of acids, of course, protracted vomiting, gastric suction, hypochloremia, low chloride might lead to that too. Too many diuretics, pulling off some of the ions that might take the hydrogen ion with them, in particular potassium. And when there's high levels of aldosterone, that can also cause it. Okay, components of the ABGs, the arterial blood gases that we are going to look at. We're going to look at the pH. Remember the normal 7.35 to 7.45. We're going to look also this time at the partial pressure of oxygen, or the PaO2, meaning the oxygen dissolved in arterial blood. The normal there is 80 to 100. And we're going to look at oxygen saturation, the SaO2, arterially, and the normal is 95 to 100 there. We're going to also look at the PaCO2, which is the amount of carbon dioxide arterially. That normal range 35 to 45. The bicarbonate, which is the bicarb that is in the bloodstream, normal range 22 to 26. And we're going to look a little tiny bit at base excess because that indicates the amount of excess or insufficient level of bicarbonate in the system and often can be used as kind of an additional reinforcement as to what we might be seeing in the acid-base balance in the blood or the body fluid. Normal range of the base excess is -2 to +2 milliequivalents per liter. That negative and positive sign there's a little hard to see. When it is negative, or there is not much base excess, it's in the -2 range or lower than -2, sorry, -3, -4, something like that. That means that yes, indeed, there is not much extra base to go around, and so there is an acidosis going on. Positive base excess, meaning that there is an excess of bicarb or of base in the system. That means that there is an alkalosis going on. So we're going to look at those things. Let's go through these steps in the ABG analysis using the arterial blood gas to evaluate our acid-base balance, our oxygenation, and then we will try to see what exactly is going on overall with the acid base. So we're going to look at first our acid base evaluation using the pH, the PaCO2, and the HCO3. Basically, there's 3 steps. Step 1, we look at the pH. If it's above 7.45, we feel an alkalosis is going on. Below 7.35, an acidosis is going on. Step 2, we're going to try and see if it's a respiratory or metabolic problem. We do this by looking at first the PaCO2 level. If it is a respiratory problem, when the pH drops, the PaCO2 should rise. So the arrows, again, will be going in opposite direction. When pH is arrow points down, if the PaCO2 arrow points up, that means it's respiratory. Conversely, if the pH arrow would point up because the pH is rising, the PaCO2 would fall if it is a respiratory condition. So we take the pH value and the PaCO2 values and we look to see if those values are moving in opposite directions. And if indeed that is true, then the problem is primarily respiratory. The third step now, we're going to look at the bicarbonate level because that will tell us if the problem is metabolic or not. So with a metabolic problem, the pH and the bicarbonate levels will move in the same direction. So when the pH increases, the bicarbonate should also increase if it is a metabolic problem. And then conversely, as the pH decreases, so would the bicarbonate if it is a metabolic problem again. So we look at the pH in step 3, pH and CO bicarbonate values. If they're moving in the same direction, then the problem is primarily metabolic. Okay, here's just a table showing you these things. Respiratory acidosis, pH drops. Carbon dioxide moving in the same, moving in an opposite direction indicates it's a respiratory problem. In this particular instance, there's nothing going on but an acute respiratory acidosis, so there's nothing unusual about the bicarbonate. If it's respiratory alkalosis, we have the opposite going on, pH rising, PaCO2 dropping, arrows moving in the opposite directions reinforces that it's truly a respiratory problem. For the metabolic issues, pH dropping, bicarbonate dropping, arrows moving in the same direction means it's a metabolic problem. Again, nothing going on with PaCO2 because this is just an acute metabolic acidosis. We're not worried about what the PaCO2 is doing when we've concluded it's metabolic at this point. And for metabolic alkalosis, pH will rise, as will the bicarb, confirming alkalosis and that it is a metabolic origin when the arrows are moving in the same direction. So let's take an example here, and we're going to just look at the little case study information. Person, female, severe asthma, having increasing shortness of breath since admission. That alone would lead me to believe she's probably got a respiratory issue going on, but let's double check, see if what she's getting for arterial blood gases confirms this. Her pH is low, arrow moving down. PaCO2 is high, arrow moving up, and bicarb 25 really not going one way or the other, appears pretty normal. So then we have the arrows, the pH and the PaCO2, the arrows moving in opposite directions, appears to be a respiratory acidosis. Again, the pH low, acidosis, arrows moving in the opposite direction means it's a respiratory problem. So we followed those steps. We assessed the pH, then the PaCO2, and then the HCO3, and that is how we determined what it was, okay? Respiratory acidosis. Treating this, we would actually try to improve the ventilation status because obviously something is happening to keep the person from getting rid of the carbon dioxide that's causing that acidic condition. So we probably provide oxygen, maybe mechanically ventilate, or do bronchodilators, pulmonary toilet, those kinds of things to improve the ventilation status. Let's look at example 2 now. We have a 55-year-old male. He's got recurring bowel obstruction, okay? And he's also had intractable vomiting. So looking at his blood gases, we see that the pH is 7.5, elevated, so alkalosis. PaCO2 seems to be in the normal range, nothing really going on there. But the HCO3, the bicarb, is 33, which is elevated. So we've got elevated pH and elevated bicarb. Arrows moving in the same direction mean it's a metabolic issue. And again, those are the steps you follow. We looked at the pH, looked at the PaCO2 and the bicarb HCO3 and found that indeed it was metabolic alkalosis. So the treatment of this person might include administering IV fluids and doing something that would reduce that excess bicarb in his system, okay? So far we've been very, very simple with the examples. We've just done simple cases. There's no evidence of compensation. Only one system is involved, which is not actually what you would see in real life, but it helps to gather the concepts or for you to grasp the concepts when we keep them simple. But now we're going to move into something a little more difficult. When this acid-base imbalance exists over time. So when the patient develops the imbalance, the body will attempt to compensate. So far we've been looking at uncompensated cases, but now we're going to kind of look at some of the cases or the arterial blood gas values when compensation is present. Remembering, of course, that the lungs and the kidneys are the main buffer responses that we can determine in the blood gas values. Again, the body will try to overcome the respiratory or metabolic issues to return that pH to normal. So a patient can be uncompensated, partially compensated, or fully compensated. When an acid-base disorder is either uncompensated or partially compensated, the pH remains outside normal. Fully compensated, the pH has returned to normal, even though other values might still be abnormal. And we will never see overcompensation because neither the lungs nor the renal system has the ability to do that. So our first two examples that we just did were both uncompensated. In both cases, pH was not normal, and the primary source of the imbalance was easy to identify, but the mechanism that might have compensated remained in a normal range. So now we're going to see what happens when that is not true. The compensation mechanism will also be a little out of the normal. So when we are trying to determine if this compensation is going on and if it's partial, first we assess the pH. That tells us if we've got acidosis or alkalosis going on. Then we look at the PaCO2. In an uncompensated state, the pH and the PaCO2 move in opposite directions when it's a primary respiratory problem. But if they're moving in the same direction, we might conclude that the primary problem is metabolic. However, it depends if indeed it is a metabolic problem. The decreasing PaCO2 may indicate the lungs are trying to correct the pH back into normal by getting rid of that extra carbon dioxide, in essence, blowing off the excess carbon dioxide. So if evidence of compensation is present, but pH has not been corrected to within normal, then you would have a metabolic disorder with partial respiratory compensation. The same thing with the bicarb. When the pH and the bicarb move in the same direction, that means that there's primary metabolic issue going on. But if the pH and the bicarb are moving in opposite directions, then you begin to think that perhaps that primary acid-base disorder is respiratory and that the kidneys are doing things with the bicarbonate level as a buffer response. So they're compensating by retaining the bicarb in an acid situation, an acidosis, ultimately with the idea of returning the pH back to normal. So here is a table showing you fully compensated states. Okay, so we've got what appears to have been, I don't have examples here, but just to kind of talk you through it, a respiratory acidosis was going on. The pH was low. Now it's normal, but it's still under the 7.4. So since the PaCO2 was elevated, and that would make those arrows in the opposite direction, it seems that the initial problem was a respiratory acidosis, and the bicarb has compensated enough to bring the pH back to normal. So it's a fully compensated respiratory acidosis. Similarly, respiratory alkalosis, the pH is now normal, but it used to be a little higher than the 7.4. We kind of take that as the midline when we're determining what happened before things were fully compensated. So since the pH was elevated before returning to normal, and the PaCO2 is decreased, arrows moving in the opposite direction, we assume that was a primary respiratory alkalosis that has now been fully compensated. Same with the metabolic acidosis. The pH is normal, but apparently is less than 7.4, our midpoint. And so we assume, since the bicarb is also moving in that same direction, so that would have caused a metabolic acidosis. That would have caused the acidosis. It is metabolic then, and it was a metabolic acidosis before being fully compensated. Again, metabolic alkalosis, pH is now normal, but slightly over that 7.4 midline, and obviously with the bicarb also elevated, it clearly was a metabolic alkalosis. Okay, fully compensated because the pH is normal, but looking at where the pH was before it was normal helps you determine if it was an acidotic condition or an alkalotic condition, and then comparing that determination to your bicarb or PaCO2 levels lets you also conclude whether it was a respiratory or metabolic condition before being compensated. Partially compensated states now, we're going to see everything kind of moving in different ways, okay? Respiratory acidosis, pH will be down, PaCO2 will be up, and if it is partially compensated, we'll see that bicarb busily working in the opposite direction of the pH to move it back toward normal. Same thing with alkalosis, pH up, PaCO2 down, and the bicarb working against that alkalotic state to bring it to normal. The metabolic acidosis, we're going to see the pH down, the HCO3 down, and the which confirms a metabolic acidotic state. And then we'll see the carbon dioxide level working in a manner lowering that should reduce the acidotic situation. Metabolic acid alkalosis, the opposite. We've got an elevated pH, elevated bicarb, and the PaCO2 elevating in a manner to bring that pH back down. So partially compensated states with the arrows showing you what you should see in those levels to let you know what it is and what is compensating. Okay. Notice the only difference between partially and fully compensated states is whether or not that pH has returned to the normal. In compensated acid-base disorders, the pH will frequently fall either on the high or low side of neutral, which in the body's case is 7.4. When you determine where the pH fell in relationship to that 7.4, helps you tell if the original problem was acidosis or alkalosis. And then from there, you can determine whether it was respiratory or metabolic by seeing what the respiratory and or bicarb levels are doing, okay? Example 3. Here's John Doe, dialysis patient, and here are his blood gas levels. He's pH 732 with a PaCO2 of 3.2 and an HCO3 of 18. So the pH is going down, lowering. So the arrow would point down. The PaCO2 is also going down, so that arrow would point down. And the bicarbonate arrow would go down as the bicarb level is decreasing. So this would mean, because the arrows of the pH and the bicarb going in the same direction, with the arrows of the carbon dioxide and pH not going in the same direction, or I mean, they're also going in the same direction, which would mean that it cannot be respiratory, it must be a metabolic disorder. So this seems to be a metabolic acidosis. And since the carbon dioxide levels seem to be moving in a direction to make things more alkalotic, right? The CO2 is lowering, and the CO2 lowers, the hydrogen ion lowers. So this is a metabolic acidosis with partial respiratory compensation. Okay? And here this is just kind of step by step talking through what I just said there. Okay? Partially compensated metabolic acidosis. Let's look at example 4 with Jane Doe, patient with chronic COPD, admitted for surgery. She has a pH 735, PaCO2 48, HCO3 28. So the pH is low, 735. Actually very low normal, okay? So, because we're considering 735 to 745 to be considered normal pH, even though it is low. Her PaCO2 is elevated, 48, and the HCO3 seems to be a little elevated also. So this appears to be a compensated, fully compensated state. Now, since the PaCO2 is elevated and the pH seems to have returned from an acidic or a lowered pH state to the normal level, this most likely was a respiratory acidosis. And we can see that the bicarb is elevated, meaning that the bicarb or the kidneys compensated. So this is a fully compensated respiratory acidosis. Okay? And these are the 3 steps just talked out in longhand here as to what I just said. Looking at example 5, we've got John Doe, pH 733, PaCO2 62, HCO3 65. pH is low, arrow down. PaCO2 is high, arrow up. So since they're moving in the opposite direction, this seems to be an acidosis condition that has respiratory involvement. So it's a respiratory acidosis. Look at the bicarb, it's elevated, and that means it's moving in a method or in a direction that will correct that acid condition. And so this is a partially compensated respiratory acidosis. Here's the steps, just talking us through that again. Partially compensated respiratory acidosis. Here's example 6. Jane Doe, 54-year-old female with ileus, nausea, vomiting with an NG tube, pH 743, PaCO2 48, HCO3 36. So the pH is normal, but it seems to be a little higher than the 7.4 midline that we look at. So she obviously must have returned from a slightly alkalotic state. So her PaCO2 slightly elevated, that would not have caused an alkalosis. And the HCO3 is elevated, that would have caused an alkalosis. So this is a metabolic alkalosis that has been fully compensated because the pH is back within normal. Okay, and here we go again with the step-by-step discussion of determining how that we arrived at the decision that that was a fully compensated metabolic alkalosis. Let's finish up talking about blood oxygenation, because we also use the arterial blood gases to evaluate our blood oxygenation. Components of the arterial blood gases that are used to evaluate this is pretty much just the pressure, arterial pressure, partial arterial pressure of the oxygen in the blood. The normal partial arterial pressure of the oxygen is 80 to 100 millimeters of mercury. Okay? We use what's called an oxyhemoglobin dissociation curve to show the relationship between oxygen saturation and that pressure arterially of the oxygen in the blood. The strength with which the oxygen binds to hemoglobin has very important clinical implications, and this oxyhemoglobin dissociation curve tells us a lot about that ability of oxygen to bind. If oxygen binds too loosely, hemoglobin might give up the oxygen before it gets to the tissues where it's needed. If it binds too tightly, it might not move to the tissues at all, but stay fixed on the hemoglobin. So we look at the affinity of the oxygen to the hemoglobin, and there's several things that will affect that affinity, or conditions that will cause enhanced release of the oxygen molecule. In other words, it lets go too soon before it gets to the tissue. Those conditions are acidosis, fever, elevated carbon dioxide levels, which we see in acidosis sometimes, And then there is a product of glucose metabolism that, when it is increased, will also cause this enhanced release or letting go of oxygen too soon. When this happens, when the affinity is enhanced where it releases too soon, it's called a shift to the right. And there's a C waveform that we use. You'll see that in a minute or here too, that gives you a visual of what that might look like. On the opposite end of the spectrum, then there's conditions that keep that oxygen molecule too tightly attached to the hemoglobin. So while it gets to the tissues, it is not released. Those conditions would be hypothermia or alkalosis or a low carbon dioxide pressure in the blood and the decrease in that substance that was part of glucose metabolism, okay? The change keeping the oxygen molecule too tightly attached to the hemoglobin is called a shift to the left, and that's a B waveform. Shift to the left has more negative implications for the patient than a shift to the right. So, hypothermia and alkalosis have more negative implications than the fever and acidosis. Okay? When we evaluate blood oxygenation, we add an additional step to that arterial blood gas analysis that we were doing. It's called step 4. We assess the pressure of the oxygen arterially. Below 80 might mean hypoxemia, depending on the age of the patient. And correction of this oxidation is accomplished by giving more oxygen. We augment the means of oxygen delivery, and then we try to correct anything that might be a problem. For example, conditions that might shift that oxyhemoglobin curve. Here's the curve that I was talking about. It's kind of in a almost an S shape. The dark black in the middle here is the norm. The right shift, where the oxygen is let go too soon before it reaches the tissue, is the part on the lower right hand side of the curve underneath that black line. That's the norm. And a left shift, which is meaning that there is decreased affinity. The oxygen is held too tightly to the hemoglobin, and even though it may get to the tissues, it's not released. And that is depicted on the upper left part of the picture here. On top of that black line is the left shift, okay? Right shift, left shift in that oxyhemoglobin curve. Here's another picture showing you kind of a dark blue line that's the normal oxyhemoglobin curve, and a red line that is increased hydrogen ion acidic condition going on there, and kind of a right shift, and then the decreased hydrogen ion with a left shift going on in that kind of lighter blue color there. So we can get a lot of valuable information from the ABGs as to the patient's physiological condition. It's only one part of our assessment, but we have to be very systematic when we look at the ABGs. We start with the ABGs, or the ABCs, sorry, and we look for hypoxia, which we can usually treat quickly. But then we will follow the 4 steps, assess that arterial blood gas status to determine if there's acidosis, alkalosis, respiratory or metabolic, and then when we're done with that, we will actually look at the oxygenation and try and determine what is going on with that status so that we can correct any problems there, bearing in mind that the acidosis and the alkalosis of the blood will affect how effective we are with giving some oxygen to the patient. Not magic, understanding just takes practice. Okay, that's the end. Thank you.